So the agenda today, we'll have a short welcome from Mary Wiley, our Executive Director with Niagara Connects. And then we'll turn it over to Kate, Samantha, and Sharon from the Center for Addictions and Mental Health to talk to us a little bit about some Niagara-based research. And then over to George from the Canadian Mental Health Association from the Niagara branch to talk about the relevance of that data in the Niagara context. And then, as I say, finally we'll open up the floor to hear from you and to have some discussion about what this all means to you and where you see this fitting in within your own organizations and your own context and the people that you serve. So I think that's it for now. We are recording the webinar, and that recording will be available on the Niagara Knowledge Exchange within about a week, but we'll also email you to give you a direct link to it as well. So I think that's it. Mary, I'm going to turn it over to you.
Thanks, Sarah. A really warm welcome to everyone from Niagara Connects. We have 90 people registered for today's learning event, which is awesome. And we're really pleased to be partnering on this webinar with CAMH to highlight their recent research in Niagara. And thanks as well to George Krasawa from CMHA Niagara for helping to provide some additional context that will enable all of us to better understand how this research and the findings can strengthen our individual work and the people that we serve. So I'll turn it over to Kate Graham and take it away, research team.
Thank you very much. Can you hear me okay?
Yeah.
I'm here with Sharon and Samantha as well. We've got our colleagues from PSSP, at CAMH, Marla Banning, Beth Powell, Andrea Flynn, and I think Cindy Smith is coming in a bit. So I just wanted to let you know we had a few extra people here, so if you hear ambient noise, it's them. And I just wanted to introduce Sam, but I wanted to say that the data that we're presenting here is part of two large projects, and it's just one piece of it, as the people who are on our Community Advisory Committee and have been involved with us for several years know there have been a number of other pieces. And so Sam's going to give a little bit of background on that.
Thank you, Kate. Turning to the background, first, the project began as researching health in Ontario communities. And some of you will remember that this project, it started off in the Niagara area in Port Colborne and Welland. This was a team project funded by the Canadian Institutes of Health Research, and it uses the CAMH mobile lab, a 32-foot trailer, to implement studies on mental health, substance use, and violence problems in Ontario communities. And a crucial aspect of this project is working closely with community stakeholders throughout the research process. But building on this project, Kate will be talking about the 5 Views on a Journey partnership project. And so this is also funded by CIHR. It involves, again, working closely with the community, with knowledge user partners, and uses data from the ROC project as well as other data sources to improve the system of services for mental health, substance use, and violence problems. And the key feature of this project is the study of these issues from 5 perspectives, including consumers, family members, the general population, service providers, and health service utilization data, which is the focus of today's talk. But first, I really wanted to acknowledge the committee that was crucial at the very, very beginning in Port Colborne and Welland. This is our the ROC Community Advisory Committee, with many names I'm sure you'll see there that you recognize in the community. And this group really was incredibly supportive from the very outset of the project. They gave advice about the instruments and protocols, and I will say that many of these instruments and protocols are being carried out today in subsequent communities that are involved in the ROC project. So we thank this group so much, and I'll turn it over now to Kate to continue talking about the ISIS data.
shuffling around this laptop here if you wonder what we're doing, and the speaker. Sharon has been doing a lot of the analyses for all of our different projects, and she worked with ISIS to do the analyses we're presenting today. So she's going to talk about the research methods.
Kate is going to present the findings for medical and hospital service use for mental health and substance use challenges for adults age 19 and older from the years 2007 to 2012. And we have data from ISIS for Welland and Port Colborne, and from the LHIN, people in the LHIN that are not in Welland and Port Colborne, and also from a random sample of Ontario residents. Oh, sorry, went too far. Okay, sorry about that. So we use the databases from the Institute for Clinical and Evaluative Sciences, and the web address is there if you want to find out more about that organization. Their database includes all of the OHIP information from across Ontario. In particular, we were interested in family physician visits and psychiatrist visits. They also have the Ontario Mental Health Reporting System, which includes all of the psychiatric hospital admissions for adults. And they have hospital and ER data, that should say actually hospital discharges, not admissions, but a small point. And also the Ontario Drug Benefit Program, and in particular we were interested in methadone prescriptions. And then people who have not had contact with physicians, hospitals, or methadone programs aren't included in the analyses. So we did these analyses in collaboration with Dr. Paul Kurdiak, who's the lead ISIS scientist at CAMH, and all of the ISIS analyses were done by Joyce Chang, who's a research coordinator at CAMH and ISIS. So to start with, to select our cases, we chose people who had a postal code, or everybody who had a postal code in Welland and Port Colborne, or in the rest of the LHIN, not including Welland and Port Colborne. We looked at men and women, and the findings that Kate is going to present are for adults 19 years and older. And so we selected people who had received a treatment or diagnosis for a mental health or a substance use or addiction challenge, and those are based on the codes that the physicians or the service providers enter. We compared those people to a sample that was matched by postal code, by gender and age, but people who had not received treatment or a diagnosis for mental health or a substance use or addiction challenge. And we also compared them to, or we also had an Ontario sample that was randomly selected, and that includes people who had received treatment or diagnosis for mental health or substance use or addiction challenge, as well as people who did not have treatment or diagnosis for those challenges. And the analysis was done separately for each of 5 years, from the fiscal year 2007 and 8 to fiscal year 2011-12, and it was averaged across the 5 years, which just gives us more stability or reliability in the data. So to identify people who had used services for mental health challenges, we extracted people who had a family doctor visit that was coded as a mental health visit, people who had visited a psychiatrist, had been hospitalized for a mental health challenge, had visited an ER for a mental health challenge, people who were coded as deliberate self-harm, or if they had received a diagnosis of mental health disorder. And those, I think those are the broader categories that you see that are based on the ICD-10 codes. We excluded people with dementia, delirium, autism, or mental retardation. And for substance use or addiction challenges, we selected family doctor visits that were coded as substance use or addiction, people hospitalized for substance use addiction, substance use challenge or addiction, people who had visited an ER department, received a methadone prescription paid for by Ontario Drug Benefits, or received a diagnosis of a substance use disorder or addiction for alcohol or drugs, or a diagnosis of a gambling addiction. So this table shows the top 7, the percent meeting the top 7 criteria, and for each of the communities. So for Port Colborne, Welland, Boleyn, and Ontario. And so the most frequent by far was the mental health visit to a family doctor, diagnosis of anxiety disorder was the second. Substance use or addiction challenges were not, people were not identified with substance use or addiction challenges as frequently because these people would often go directly to addiction services or are more likely to be identified in social services or the criminal justice system rather than being covered by OHIP. And plus there may be a general under-recognition of substance use or addiction challenges by the medical services. And this slide is showing, I guess, the composition of this sample, and the thing, I guess, what it shows mostly is that the cases that Kate is going to present, the findings that Kate is going to present are mainly, were mainly identified as having a mental health challenge. And again, the substance use or addiction challenges are probably under-identified in this sample. I think that is it. So thank you. And now Kate is going to present the findings from these data.
Okay. Thank you, Sharon. Okay. So what we wanted to find out from these analyses was how much service was being used by people who had mental health and substance use or addictions challenges. And we divided them into 3 groups. Mental health only, so they were identified as only having mental health problems. Substance use or addictions only, or both mental health and substance abuse addiction. And I'm going to go back to the slide that Sharon just presented because that gives the numbers. So for example, in Port Colborne, we identified 2,000 people who had mental health only, 145 who had substance abuse addictions only, and both with 142. And you can see the numbers for the other different groups. Okay, so we first looked at annual number of hospital admissions per person by mental health or substance use addictions challenges for the total number of visits, so the number of visits for any reason, and then we also moved out there's several graphs like this, so we'll go through this one fairly slowly and then you'll get the idea. And so this is per year, per person, but it's over a 5-year period. So what we did was averaged it over the 5 years. This makes the, your annual fluctuations are blurred a little bit from, are averaged out. Okay, so I need my arrow here. Okay, so this arrow here is our control group. And I'm looking at Welland right now. So they had 0.08 hospital admissions per person. These were the people who using our criteria, were not identified as having mental health or substance use addictions challenges. Maybe I'll just say MHSA, if that's okay with everybody. Okay, so, and that's in blue, and so if they had a visit for mental health or substance use, then they would have a little white bar, because the white bars are for those reasons. Then the next group is the mental health only. So as you can see there, there's a total, they had a total of 0.17 hospital admissions, 0.12 that were not identified as mental health, and 0.05 that were identified as mental health. So, you with me on this one? People in the room here, they can follow. Okay, so the next one are the people who are identified as having substance use or addictions problems only. So they had 0.13 hospital admissions that were not identified as substance use or mental health, and 0.09 that were. And then this group here is the people who are identified as having both kinds of problems. So they had a total of 0.55 hospital admissions per person. That's one admission for every 2 people who had concurrent problems. So you can see, and you can see the same pattern for Port Colborne and for the Lynn overall and for the Ontario sample. So they're all pretty similar looking, a little bit of variation on it. So what we have are the ones with mental health only. In each of the geographic areas had about twice as many hospital admissions. The substance use only had about 3 to 5 times as many, depending on where they were located. And the mental health and substance use addictions people had 7 times as many hospital admissions compared to this group over here with no mental health or substance use. So now I would normally ask people if they had any questions. But you folks here in the room are following, are you? Okay, we'll move on to the next one then. I have to give that arrow, I guess. So this is actually the numbers over the 5-year period, which shows it's pretty stable, and there isn't very much. And these are the hospital admissions each year for any reason by people who have had an MH or SA problem or challenge. So relatively stable over the time period and not very much different geographically. So I will be talking about hospital admissions, ER visits, and primary care physician visits. So there isn't, and then that's basically the whole presentation. So this is for ER visits. Again, maybe we'll look at Port Colborne this time. So they had 0.7 ER visits per person if you had a Port Colborne postal code. That's how people were selected. And if you'd ever used the system, you had to be in the system to have used it. So out of the people who've used the system, 0.7. For mental health only, it was a total of 1.4. So again, we have mental health only about twice as many admissions as for people who had no mental health or substance use issues. And then for substance use only, we had 1.9 for Port Colborne, a little bit higher than some of the other ones. So this was 3 to 4 times as many compared to this group. And the ER visits, we have 3.2 for Port Colborne, 2.5 here, 2.7 here, and 2.4 here. So that was about 9 times as many I'm making 9 times. Is that right? Right. It's 9 times as many for these ones. It's a little bit different for Port Colborne because their no MH or SA group has rather a high number of ER visits, which we can talk about as well. So we get about 9 times as many ER visits, and most of them are not coded as mental health or substance use. So you see how small the white bar is? So for example, for the LIN, of the 2.7 visits per person of people who had concurrent problems, 1.8 of those were not designated in the file, in the records that went in, as being related to mental health or substance use addiction. Oh yeah, I was pointing with my little arrow. I should bring out the arrow for that. Sorry about that. Okay, so then this is the 5-year period. Again, a fairly stable pattern, and the higher emergency room use in Port Colborne is fairly evident. Okay, so by now you're used to looking at these. And this is first physician. And this time I'll turn the arrow on again, which I forgot to for the last one. And we can maybe look at the LIN. So there was 4.7 physician visits for the non-MH or SA people. 13, around 10 for the mental health only. Around 17 for the substance use only, and around 22 for the mental health and substance use, so people who had concurrent. And so this we had, mental health only was about twice as many as we've had on the other slides. Substance use was about 4 to 5 times as many, depending on the area. And for the concurrent people, it was about 4 to 5 times as many.
And Kate,
Yeah?
Sarah's here. 5 to 7 minutes.
Pardon?
I'm just giving you about a 5 minute.
Yeah. No problem.
Thank you.
Okay, so again, relatively stable patterns, a little bit of increasing in Ontario, and the Ontario physician visits from our random Ontario sample seem to be a little bit higher than from the other samples. I'm just going to show this for a minute. So these are the same results from the LIN, and just to talk about the differences between hospital admissions, ER visits, and GP visits. As you can see, for the hospital admissions, a fairly large proportion of them are identified as having mental health or substance use as an issue in their visits. ER, very few, much less, so 33% of the ER visits of the people with concurrent disorders. And then the physician visits had a fairly large proportion. So you see where they're being identified. And then the other issue is for the ER, it was 9 times as many for the concurrent disorder people, 7 times as many for hospital visits, and about 5 times as many for GP visits. So you see the concurrent impact of concurrent disorders. Okay, the summary. So, persons identified as having MAH or SA challenges had higher rates of hospital admissions, ER visits, and primary care visits. It's a fairly simple theme here. It just takes a while to understand those graphs. This was especially true for those identified as having both MH and SA challenges. The high rate of use by persons with both MH and SA challenges was especially evident for ER. This pattern was evident for all geographic areas. And by the way, we've also done analyses for Windsor, Leamington, and it's the same pattern. Some of the additional visits by persons with MH and or SA challenges were not coded as MH or SA visits, and this proportion was highest for ER visits. Port Colborne residents had higher rates of ER use compared to the other geographic areas. Conclusions. persons with SMH or SA challenges account for considerable use of the medical and hospital care system. And so I have some questions for discussion at the end about what all this means, but I think that slide's probably going to be shown later on. Some caveats. The analyses are based on treatment and diagnostic codes made by medical staff, so the accuracy of the findings depends on the accuracy of the person doing the recording. So we knew in advance we would be under-identifying people with substance abuse or addiction challenges. So these are likely an underestimate of the number of people, and we're probably getting the more serious people. With regards to mental health, because so many were identified in a mental health visit, so if you went to the physician to get an antidepressant or something, you would have been identified. So they're probably more representative of the whole range of people with mental health problems. ROC and 5 views focus on mental health, substance use, and violence, but violence is not well measured in the healthcare system, and we were discouraged from trying to include it in these analyses, so therefore we didn't include it, I think. Oh, there's a discussion question. Sarah, did you want these to be left till later?
They were just kind of a primer there, and then we'll...
Sorry?
They were just a primer there, and then we'll come back to them.
Okay. Do you want me to read them, or?
No, that's okay. You can keep going.
That's the end. Do you want me to read the discussion questions?
Oh, no, I didn't know if you wanted to do your summary.
Oh, do I have a summary here? I've done the summary, didn't I? I did the summary.
Oh, okay. Then that's great. That's fine. We'll move on to George now. So thank you very much. It's so interesting to be able to see data at a local level, but also be able to compare it a bit wider than that as well. So I'm going to turn it over to George Kurzweil now, who will speak to us a little bit about what's going on in the Niagara area that's related to this population in particular, and how this kind of all intermixes together. So George, over to you.
Thank you. Do you hear me okay?
I can, yep.
Okay, great. And okay, I've got my first slide up. That's good. Well, I'm excited for the opportunity to talk about this over this medium here and have everybody participate. I was asked to talk about some of the broader issues, and I'm going to do that, start off with that, and then some specific examples. My task was to talk about the so what. So in terms of the broader context, the state of mental health and addiction services, first of all, I'll start off with a couple of quotes from the
George,
study.
sorry to interrupt, but we're having a couple comments that you're quite difficult to hear right now. Can you move any closer to the phone, or I'll speak up?
Is that any better right there? Hello?
It sounds a bit better on my end, but if I can get someone else to type in. Keep speaking. George?
Hello? Is that any clearer?
It's a bit clearer, yeah, bit better. Okay.
But still not very good?
People are saying it's a little bit better. It's just you're a bit faint.
Okay. Part of the problem was while I was listening to the previous presentation, I put it on mute. Now I can't take it off the hands-free mute. I can call in again if that would help.
No, I think they're saying you're good now, so keep on going.
I'm good now. All right. One of the comments from the ROC study was that addiction is caused by mental health problems in the first place, and then we turn to the drugs, figure it out on our own, and eventually go beg our family doctors for help, or there is a crisis. And another one stated, the psychiatrist rushes me out. I don't even get a chance to talk. He just thinks it's just the drinking that's the problem. So it's not surprising, and we've been hearing this from the clients, that the survey found a need for more services, and particularly in South Niagara, which suffers from a severe shortage of community psychiatrists and community services in general. As an example, in the broader Niagara area, there's only one assertive community treatment team, whereas London, with a smaller population, has 3. Hamilton, by the way, has 2 teams. We have a well-known shortage of psychiatry, and we have an inadequate basket of services. On the usage part, we know that this population is representative of what Ministry of Health has been telling us at a broader level, that anywhere from 1 to 5% of the people are using 66% of the healthcare dollars, and those are the expensive ones, not always appropriate, and that's the emergency services and in hospital services. HealthLinks has specifically been set up to deal with these high rates of hospital admissions and readmissions. You've seen the numbers for hospital visits for this population, and some of these individuals are going up to 53 times a year. And you mentioned that for some of the individuals here, they're up to 9 times the average individual. In Niagara Southwest, for example, just over 16% of the high users are visited for mental health or substance abuse. In terms of the resources, everyone knows that healthcare expenses have been going up. We're up to from $30 billion in 2003 to over $47 billion. But there is a real disparity both in the terms of the distribution of the funds and across your sector and how the funds are utilized. So that hospital gets the majority of the funds, community services gets a smaller portion, about 35% for hospitals and 6%.
George, sorry to interrupt again, but you're fading out at the end of your sentences a little bit.
Okay, I will try and speak clear.
Thank you.
There's also a large disparity per capita spending on community health services. The range on per capita is from $18 roughly to $124 across the province. And I don't know the measurement for our specific sub-area, but for Arlene it's only at $35, which is about 3 from the bottom in terms of per capita spending on mental health and addictions. If you look at, however, the global reports, the statements that they are making is that we're fairly well-resourced, with some exceptions, but we just don't use our resources appropriately. There isn't any dispute that Niagara is underfunded relative to other parts of the province, but the issue is much more complex and relates to the organization of our delivery system. So on to the next part. The next slide. Okay. So now I'm going to talk about some of the more broad themes that are emerging as a response to some of these issues. Niagara has 16 agencies, including the hospital, that are funded to deliver mental health and addiction services. All of these separate organizations have historically worked as independent entities within their own hierarchy, individualized plans, vision, mission statements, and top-down planning to a certain extent. That's changing. The services are newly engaged in collaborative work, which is absolutely necessary for us to improve our services. It's not likely there will be additional funding. The 3 broad themes that you see on your screen reflect the type of system changes that are occurring in our sector. And really one of the best examples currently of the cultural shift is found in the Niagara Mental Health and Addictions Charter. And the charters are a common agenda. It talks about breaking down traditional power hierarchies of the typically medical large institutions and their dominance, and focusing on our collective identity, common issues, and a common philosophical framework. The process of crafting the charter exemplified bottom-up relationship building that was necessary. And to paraphrase a quote from the framework document, by collaborating and coming together with shared research questions and answers, new ideas and innovations for sustainability are created. The project started with a 2012 environmental scan of over 100 groups in mental wellness and illness prevention. How's my time so far? You have 5 minutes?
Yeah, about 5 minutes. And George, you don't have a handset, do you?
I'm speaking into my handset.
Oh, you are? Okay.
I am.
Okay.
Still not coming through clearly?
It's just a couple problems with it fading in and out.
Okay.
But if you've got the handset, then yeah, just keep
speaking directly
spelling into that. Thank you.
All right. Over 100 groups were working in mental illness prevention, and mental health services. And just 2 weeks ago, the Charter Governance Breakfast brought together over 80 board and administrative reps of Niagara agencies, many of who have committed to ongoing promulgation of the project. The Charter is not intended as a static website placeholder. It's a living, breathing document, and that will create some tools for change. And some of these tools mentioned in the Charter are respectful interagency relationships, alignment through shared accountability and common data sets, mutual objectives among agency partners. So what? Well, the so what, I have a few examples of this in action. And one of them is the Urgent Services Access Team. I'm not going to read to you all of the what's on your screen there, but there are 3 slides here that I'll run through, give you an idea of what the Urgent Service Access Team operates. It's an interdisciplinary team, and it's mobile at a variety of locations. The service was a creation of 4 agencies working together to service a very challenging and underserved or poorly served population, of which this research spoke to very directly. Those that have both mental health and substance abuse issues, and particularly opioid addiction. And they are the heavy users of the hospital system. The group of agencies continue to meet as the program was funded and designed not to work in isolation, but to develop whatever initiatives were necessary for integration of the services on behalf of this population. So for example, leads from each agency have been designated to discuss transfers and support between the agencies. In another example, points of service have been established in various locations, including the hospital. USAC came into existence because there was a realization that no one service could do it alone. And working together with limited resources, these resources could be amplified and to reduce dependence on the expensive hospital services and to provide more relevant care in the community. So it's an example of an effective collaborative example, kinds of things that the Charter speaks to. In the next example, we talk about how parts of the Charter are exemplified in the mental health and addictions access line. The need for this project was clearly identified in 2012 LIN planning, actually. Improved access to care was identified as a priority by people in the larger LIN area. A lot of confusion as to where to go and who to see in terms of mental health and addictions services. Seniors were ranked as, by the way, as the top identified high-risk seniors need, and second to that was the mental health and addictions population. As a consequence of some of the initial work by the LIN, a planning session was held with all of the Niagara mental health and addiction agencies in the spring of 2013. And they're the ones that identified having a central call-in location for individuals seeking service was really a key need in our area. The clients and service providers were actually clients had identified their primary service need. How do I know where to go? How do I even know where to access my services? And this is an example of responding to that. The project has built on strong collaborative efforts right from the design area. And while this project does not create additional services, which are still needed, it will in the long term, much like USAC, identify areas of further collaboration. And I think there'll be a synergy that will create more efficiencies for clients. So both USAT and Access Line are built on some of the foundations that are elaborated in the Charter, and that's really a collective vision and shared agreement to provide better services for clients, the kinds of clients that were identified in this research. Thanks. Thank you. That's it.
Wonderful. Thank you very much, George. We do have a couple questions that came in, and as well we do have some discussion questions that we can open up as well. But first, I know people have been asking throughout. So firstly, we had Corinne asked back when Kate, I believe, was speaking and talking to the data. Kate, if a client attended a community health center which does not use OHIP numbers for remuneration purposes, would their data be included in your report? And you may have to press *7 to unmute your phone.
Can you hear me now?
I can, yep.
No.
Okay, no. Thank you.
But
Fiona asked, who gets to, I think this is once George was speaking, who gets to see a psychiatrist these days?
The question is, who gets to see a psychiatrist?
Yeah.
Oh, lucky people. We have an extreme shortage of community psychiatrists, not so much the issue in, if you're admitted to the hospital, you get to see a psychiatrist, and they are on the way to filling their quota of psychiatry at the NHS. In the community, unfortunately, it's hit and miss. We just had one psychiatrist move out of the area, and apparently he had 3,000 patients.
Wow. That would certainly have a very big impact, of course. This is for either George or perhaps Mary as well. Fiona asks, who has input to creating the Mental Health and Addiction Charter? I know the list is long, but can you give us a bit of an idea?
Can you hear me?
I can.
Okay. I hit the right button. It's Mary Wiley here. So the groups that were involved in the building of the Mental Health and Addictions Charter, the list came of folks that were invited to the original forum, came out of the work of doing the 2012 environmental scan. So in that scan, we had identified over 100 agencies, organizations in Niagara who worked either in the area of mental wellness promotion, mental illness prevention, or mental health services. And from that group, we did an online survey, and there was over a 50% response rate to the survey. So from that work came the list of organizations that were invited to the original forum on May 15th of 2013. And then we had some other groups who sort of joined in along the way. Either they heard about it and wanted to be involved. And literally at any point, any other additional groups or folks that want to join in are more than welcome. And presumably where this is heading is that the community is now going to be putting the charter into not just building it, but implementing it. So any other groups or individuals that want to be involved going forward are more than welcome. And George, if you have anything to add, you just go right ahead.
No, it's truly been a building up from bottom up, or a grassroots building, and including all of the evidence that we could gather and documentation. So it's been a very thoroughly reviewed and developed by the Niagara community as a whole.
Great. And Mary, I've put your email address in the chat pod there for anyone to, if they have more questions, they want to learn more about the charter, they can reach out as well.
Thanks.
Krista asked, George, this is a question for you. If you could please share the source of the funding formula for mental health funding that you quoted at the beginning of your presentation.
The funding formula?
Yeah, Krista, this was
not
Krista.
Not sure what you're referring to.
Yeah, Krista, could you maybe unmute your phone line by pressing *7 and just clarify a bit?
Hi, it was George, you were talking about the number of dollars per resident for funding at the beginning of your presentation.
Oh yes. Yeah, I can send that to you, Krista.
Okay, thank you. That'd be great.
There's a breakdown chart, and I believe that comes from the Strategic 2020 2012 plan of the LIN. I was involved in the strategic planning, and they did a presentation. So I will send it to you.
Thank you. And how do I mute now? Star
6.
Thank you.
Just Mary here. I'm wondering if that's actually some information that could be put. Sometimes with these webinars, we do a follow-up document that has any answers to any additional questions or any links to resources. So if that's actually information that would be of use to the whole group, perhaps we could make it available. But we'll follow up with George to see if that's possible.
Yeah, that's not a problem. I have a lot of my source material comes directly from Arlene, as I mentioned, through the strategic planning process. So I'd be happy to. Those documents aren't confidential or anything. I'd be happy to pass them along.
Great.
Great, thank you, George. So we'll put together a package then with that information, as well as a PDF of the slides you've seen today and the recording as well. And everyone on the phone will get that within about a week. We do have another question here. I think this is specifically about the access line that you were speaking about, George. Are clients concerned about privacy issues with a single call-in center model? Have you heard anything about that?
Yeah, I don't know if Stacy's on the line. I don't know if I saw her name. She's the executive director of the Distress Center and operates the. She would be better able to speak to it. I can speak to it in general terms, in terms of confidentiality. It's operated by the Distress Center. They have a long history of dealing with confidential issues through their crisis lines 24/7. So they have very well-trained volunteers who answer the phones and certainly maintain confidentiality within the legislation. Does that answer your question?
I will leave it to Fiona if you want anything else, to type it in the chat pod or else verbally speak up if you would like any more details about that. I see that, Ian, you have your hand up. Did you want to verbally ask a question? You can do so by pressing star 7 to unmute your phone. Or perhaps you were just testing out some of the features of this platform, which is okay too. Nicole asks, with the stats that we're seeing, do they take into consideration about leaving some hospitals open, i.e. Welland and Port Coburn? Kate, perhaps that's for you. You may need to press star 7 to unmute.
Yeah, I'm not sure I totally understand the question.
Oh, Nicole, can you unmute your just clarify? Nicole? Or else perhaps type into the chat.
Question is, with the high amount of stats that you've shown us for Welland and Port Coburn, don't you think that before they make the changes of moving the Welland Hospital, maybe these stats should be taken into seeing that so many visits are being made for mental health?
Yeah.
If my question is too tough.
Well, I mean, yeah, so obvious. Yeah, I think so. I mean, it's not necessarily the case that you know the people are getting the services they need when they go there anyway, which is one of my discussion questions. But it does certainly speak to the issue of local hospitals. And I personally live in a small town, and we constantly protesting to keep our hospital. So.
Too obvious.
That's a nice segue, though, into some of our discussion questions that we do have on the screen. I invite anyone, any of our participants, our folks at CAMH have done a great job here kind of posing some questions and challenges back to us in terms of how we think about this data. So does anyone have any comments or further questions related to the discussion questions on the screen? You can either type into the chat pod or else press star 7 to unmute your phone.
Mary here. I have a question. It was back to the question that Corinne raised earlier. I guess I'm just asking, going forward, if similar research was being done, how could we capture the additional information that would come from community health centers in the whole bigger picture of gathering data like this? I don't know who answers that, but
I would like to at least talk about it first, because it's something I meant to present at the end, and because it wasn't written down, I forgot. You know, when we got involved with this project, our hope was to be able to look at all of the different agencies who are dealing with mental health and substance use challenges. So that would include these hospitals. So we have hospital data, and we have DATIS data, which is the Drug and Alcohol Treatment Information System. We were unable to get OCAN data because they don't store postal codes, so we can't do it geographically. And the other thing is that none of these systems are linked to one another. So if they were all linked, then we could find out a lot more about how these services are being used. For example, how many of the people who are using the ER also are using community programs or CHCs or you know, so right now the technology isn't there, but you can really see the value of being able to look at that.
Thank you. It sounds like it makes a lot of sense.
Any other comments from those on the phone?
Well, I can start off with the first question about primary care physicians. If you look at the graphs that you presented in Fort Colborne, the hospital use and the use of physicians is directly related. They're sort of at opposite ends of the spectrum, so to speak. And it's just utilization of hospital is not only the more expensive option, but it's not always the best option for individuals, but it is sometimes the only option. So it's a problem of lack of local services. The issue of, however, the GPs in Niagara have caught up quite a bit. We were an underserviced area. We're not anymore in Niagara. The next stage is to actually link them, and that's what HealthLinks is all about. HealthLinks is there to, you're asking, do they have the ability to coordinate with other services? And that's precisely what HealthLinks is doing, is linking the GPs to other services that they may not have had the connection with in the past, community social services, mental health and addiction community agencies, so that they can provide a better spectrum of connected services with transfers in between. So there are some changes happening to affect a better service in the community. So getting people out of hospitals is appreciate that where there's a lack of service is the only choice, but it's also the better choice as long as there's somewhere else to provide service for them, and that's in the community. That's the best place to service individuals.
May I ask a question? What has been the reaction of GPs to what really is a real broadening and deepening of their practice?
Do you mean specifically to HealthLinks, like to the HealthLinks initiative?
Well, yeah. I mean, are they aware of that? I mean, I know that the government did make some noises last year in the budget about the fact that family doctors' roles were going to be changing, and I found myself thinking there always seems to be one portion of the system that seems to be going to be bearing the brunt, and it does sound like it's going to be the family doctors. I just wonder what their reaction is.
Mm-hmm.
Well, I can answer that to a certain extent. Not the expert on HealthLinks. So there's 4 in Niagara. West Lincoln had a head start in terms of getting doctors on board and getting their business plan, but they've now all 4 of them at this point have submitted business plans to the LIN, and they've all had a percentage of doctors that have signed up to HealthLinks. Some of the people out there that are listening in might have a better idea of specific areas, but to my knowledge, doctors have been signing up to the health links.
And they have to, I mean, that's a formal process?
Yeah, it is a formal process. There are physician leads that are assigned for each of there's 4 sub-areas in Niagara, sort of northeast, southwest, that kind of a thing. And there are physician leads that have been identified. I don't have their names in front of me, but they are somewhere. And their job is to access the other doctors and get them to sign on and agree to be part of the health links. Yes, it's a formal process.
And would one, I mean, if you have a family doctor, will that doctor tell you as a patient that they have signed up to health links?
I don't know that. Can't tell you that.
No, I mean,
Is anyone else on the phone able to answer that? Is anyone else involved in a health link that they could respond?
It's Coletta McGrath from Quest Community Health Center.
Yep. Hi, Coletta.
Hi there. I'm just actually going back a few steps in terms of the question around physicians and working with individuals with mental health, addictions, concurrent disorders. One of the observations that I would make, obviously particularly here in Niagara, is that we have 4 community health centers. 3 of those are relatively new in that they were funded in the last round of funding for CHCs. The mandate of community health centers is to work with marginalized populations challenged in accessing the primary health care system. As a result of that, for most of the CHCs, a very significant number of the individuals that we work with have mental health, addiction, and concurrent disorders. George spoke earlier to our urgent service access team here at Quest and the fact that we developed that in conjunction with the Niagara Health System, with CMHA Niagara, and with Community Addiction Services Niagara. But once again, focus being individuals, mental health, addictions, and concurrent disorders. We're also working very closely with the hospital around discharge planning to make sure that those individuals who do end up in the hospital are referred back to community health centers once they're being discharged. So I guess I would emphasize and re-emphasize that the mandate of CHCs is very much to work with individuals with mental health, addictions, and concurrent disorders, recognizing that those individuals require an interdisciplinary model of care, that it's much more likely that they will make use of that model of care if every service is accessible within the same building, i.e. a hub model. And CHCs have been around since 1974 based on that premise and those principles.
Thank you, Coletta. That's a great comment. Any final questions or comments before we sign off today? Okay, well, thank you very much to our presenters today, to Sam, Kate, and Sharon for sharing the data about what's happening in the Niagara region, and then George for kind of helping us answer the so what. What does that mean for us? And to all the participants who took the time today to join the discussion. As I said, the recording and any resources will be emailed out within the next week, and I encourage you to forward on to your colleagues who may not have been able to attend today. Other than that, please do check out the Niagara Knowledge Exchange. We put the website there in the chat pod. If you haven't already been on it, we've got lots of events, resources, projects, blogs to kind of help you make sense of what's happening in Niagara and have access to information that can help inform your own decision making and planning. And certainly if there's any resources, events, projects, blogs that you would like to share out with the Niagara community, please be in touch with us and we'd be happy to help you do that. I'll leave our contact information up there, but other than that, thank you very much, everybody, and have a great rest of your afternoon.
Thank you very much. This has been